Shifting gears a little bit, we're going to come to the one of the most important aspects of our conference is our poster session, our annual poster session, and our annual abstract competition. We received almost 150 abstract submissions this year, and this morning you're going to hear from the top three, those who were selected as the top three. Can we bring up those slides, please? All right. All right. So the first award winner, and these folks know that they've won an award, but they don't know if it's first, second, or third place, and they will find out this evening at our crawfish boil. And these come with big cash prizes. We're one of the only conference in the country that gives cash prizes to trainees for abstract awards. So make sure to come to the crawfish boil to see which are selected for which award. The first is a really important topic. As you all know, CAGLA has been very, very active in passing laws to promote genetic testing, precision medicine, biomarkers, and so on and so forth. But insurance companies don't always follow the law. And the analogy I like to use is if I walk down the street punching people in the face, I'm probably going to get arrested at some point. And if I look at the cop and say, sorry, I didn't know that was illegal, or I haven't had time to update my policy on punching people in the face, I only do that every 2 years when the committee meets. It's not much of an excuse, but those are the exact excuses insurance companies use to break the law each and every day. And our insurance commissioner holds these people accountable. Recently, the insurance commissioner, Tim Temple in Louisiana, published probably the strongest worded letter I've ever seen from any insurance commissioner about following this particular law, and basically told insurance companies there's no getting around it. There's absolutely have to follow the law. There are no exceptions. But the research we're about to hear from Joshua Seibecker, who is a third-year medical student at LSU Shreveport, and I hope Joshua's here. Great, glad to have you. Glad to have you. Come on up. Is about just this. How was the law impacted? Did the insurance companies actually follow the law, and did it change genetic testing? So I'm anxious to hear it. Thank you.
Thank you, Dr. Matrana, for that introduction. I like your analogy. Good morning, everyone. My name is Josh Siebeneicher, and I'm a third-year medical student at LSU Health Shreveport. I'm honored to be here today and have the opportunity to present the findings from my summer research project. I will be discussing how Louisiana Senate Bill 84 influenced access to next-generation sequencing for our patients at Weisweiler Cancer Center in Shreveport. I think we can all agree that as precision medicine becomes increasingly central to oncology, ensuring equitable access to genomic testing is no longer optional. It is essential. Okay, so next generation sequencing, also known as NGS, enables the simultaneous DNA and RNA sequencing of hundreds of genes up to the whole human genome. This is so important because we know that most tumors harbor multiple genetic mutations, and traditionally, identifying these mutations required multiple separate molecular tests. However, with the advent of NGS, we're now allowed to have a single assay approach. We can detect multiple variants and multiple mutations with one assay. In oncology, targeted NGS panels can be selected based on disease type, and the results of these panels are routinely used to guide diagnostic classification of disease, the selection of targeted therapies, and then also prognostic assessment for the patient. Despite the clear clinical value of NGS, access has historically been limited by inconsistent insurance coverage and variable prior authorization requirements. We know that coverage policies differ widely among payers, and this often results in delays and even outright denials that postpone critical treatment decisions. In response to these challenges, our state enacted Louisiana Senate Bill 84, effective in January of 2022. Senate Bill 84 mandates insurance coverage for next-generation sequencing and genetic testing when ordered by a treating oncologist or hematologist. The passage of Senate Bill 84 was strongly supported by efforts from the Cancer Advocacy Group of Louisiana, and I know many members of the audience here today played an integral role in advancing this legislation in Baton Rouge. The intent of this legislation was to standardize approval processes, reduce delays to testing, and expand overall access for patients in our state. We wanted to see how Senate Bill 84 influenced our population up in Shreveport. Our objective was to evaluate the impact of this mandated coverage on insurance approvals, NGS utilization, and overall survival outcomes for patients seen at Feisweiler Cancer Center with NGS orders from Feisweiler Cancer Center Genomics Lab. Each year, our lab processes roughly 300 NGS orders, giving us the adequate sample size for this pilot study. I'd also like to include a little background information about our lab. We were established in 2017, and we are currently accredited by both the College of American Pathologists and the Clinical Laboratory Improvement Amendments. Our laboratory currently utilizes the Illumina TrueSight Oncology 500 pan-cancer panel, and this panel allows for comprehensive genomic profiling, including assessment of tumor mutational burden and microsatellite instability. I'd also like to add that this study coincides with an important transition period for our lab. In 2020, our lab, like so many labs across the country, shifted primarily to COVID testing. And then in 2021, the lab developed the current NGS protocol that we use today. So 2022 is a very important transition year. It's the first year that our lab had its current NGS protocol in place. It is also the first year that Louisiana enacted Senate Bill 84 and mandated insurance coverage for next-generation sequencing. Moving along to our study, the following flow diagram outlines our initial cohort selection and analytic approach. We began with an initial cohort of 711 patients, and these patients had an NGS order placed between 2022 and 2023 at our genomics lab. We then excluded 93 patients based on predefined study criteria. We excluded patients younger than 18, older than 95, those with an incomplete NGS order, and also patients who were currently incarcerated. After applying these exclusions, we were left with a final cohort of 618 patients. For this cohort, we then gathered detailed data, including general demographics of age, gender, and race, cancer type and pathology data, including staging, insurance approval status, and also date of last follow-up or date of death. After creating this final cohort, we then began our initial review. We evaluated NGS approval rates stratified by payer type and assessed patient outcomes on date of last follow-up. We then conducted statistical analyses stratified by payer type, demographics, and progression-free survival to better understand differences in approval patterns and clinical outcomes. Notably, the payer distribution in our study population is nearly the inverse of the statewide pattern. Statewide, 44% of patients are privately insured. And then the chart on the top is our data from 2023 for our state. So statewide, almost half the patients are privately insured, but in our population at Feisweiler Cancer Center, only 14% of our patients have private insurance. In contrast, 46% of our patients were insured by Medicare, whereas only 14% of patients statewide have Medicare coverage. Additionally, the proportion of Medicaid patients in our study was about 10% higher than the statewide average at 41%. So I'd like to say that this difference, while it is a stark contrast, is not necessarily unexpected. Academic medical centers and teaching hospitals often function as safety net institutions, and we care for a disproportionately higher share of Medicare and Medicaid patients, especially when compared to the community setting. As a result, our findings may not be directly generalizable to the broader statewide population. In our pilot study, 55% of our patients experienced either a denial or delayed approval for NGS testing. For context, the nationwide Medicare denial rate in 2021 was 33%, which is notably lower than what we observed. We grouped patients by payer type. Our payer types included Medicare, Medicaid, and then all private payer insurance companies together, we found that there was no statistically significant difference in approval, delay, and denial rates among payer type. We then assessed by gender. Males and females did not have significantly different approval, denial, and delayed approval rates. Our population consisted of primarily white and African American patients, but we found that approval and denial rates did not significantly differ by race. Finally, we looked at the impact of Senate Bill 84. In 2022 and 2023, we found that approval and denial percentages did not significantly differ. Less than half of our patients received initial approval for NGS testing. This persistent denial led our lab to look for outside funding. In the late quarter of 2023, we received private funding that secured NGS testing payment for patients in 2024 and 2025. Due to this private funding, we do not have data past 2023. However, we do have 2 years of follow-up data at least for all of our patients in 2022 and 2023. Now, following along, I know I've given a lot of descriptive information and statistics, and some of y'all might be thinking, well, how does NGS testing change by payer type? By cancer type, excuse me. And after all, it's a valid question. Cancer is not just one disease, it's multiple different pathologies. I would like to say that given the pilot nature of this study and the limited number of patients within each cancer subtype, meaningful subgroup analysis was really only feasible for our colorectal cancer cohort at this time. And for our colorectal cancer patients, the payer distribution was similar to our overall population, predominantly Medicare and Medicaid coverage. And additionally, I'd like to note that only 42% of patients in the colorectal cancer cohort received initial approval for NGS testing. In our cohort, among patients who experienced an initial denial for testing, Medicaid patients with an initial denial had a significantly lower overall survival compared to privately insured and Medicare patients, with a p-value of 0.0017. Now, I'm not saying that the denial of NGS alone led to poor clinical outcomes, but I am saying that the denial of NGS is a part of a larger clinical picture. We suspect this lower overall survival reflects broader systemic and socioeconomic barriers. Genomic testing may function as a surrogate marker for overall access to timely, comprehensive oncology care. These patients may also experience delays in testing, screening, and reduced access to primary care in general, and this can potentially lead to a more advanced disease state at presentation. Additionally, we are a safety net institution, and we often care for patients with a higher comorbidity burden and a greater clinical complexity. Overall, in this pilot analysis, approval for next-generation sequencing remained inconsistent across payer types despite the implementation of Louisiana Senate Bill 84. We did not observe a significant change in approval rates between 2022 and 2023, nor did we detect differences when stratified by race or gender. However, in a subgroup analysis of colorectal cancer patients, those insured by Medicaid who experienced an initial denial demonstrated a significantly lower overall survival compared to privately insured and Medicare patients. Overall, Senate Bill 84 represents meaningful legislative progress. The denial of NGS persisted. I'd like to address a few limitations head on. Our study is primarily composed of Medicare and Medicaid patients. While the bill, Senate Bill 84, is primarily geared towards regulating the private payer industry. Additionally, we only looked at next-generation sequencing. In Senate Bill 84, it mandates broad coverage for molecular testing, which includes NGS, but also every other test in the field of genomic testing. But ultimately, the fact remains that NGS testing was still denied in our state despite the passage of Senate Bill 84. This shows that policy reform can only be as effective as its implementation. So despite our progress, the fight is not won. Ensuring equitable access to genomic testing remains an ongoing priority in the delivery of cancer treatment in our state. Thank you for your time today. I've included my references, and I'm happy to take any questions from the audience.
Well, I just have a comment. I think this is phenomenal and terrific research, and I hope you publish it. I hope you publish it, because this is something we really need to disseminate. And this is the type of data that we would really like to share with our elected officials, because our elected officials feel like once they pass the law, once it's been signed, that's it, it's done. But what we see is that may not always be the case. Like you said, implementation is really, really important. But also, I think you guys are really smart to look at outside funding, because we can't rely on the payers for everything, because we know they're just not reliable completely in every case. I work at Oxford, and through sort of complex arrangements, a lot of our patients don't have as much responsibility through data sharing with the folks who do the sequencing and that sort of thing. And so we bring value to them through the data, they bring value to us through the sequencing, and it works out really well. So alternative arrangements, I think, are really important to fill the gap where the payers fall short. But this is terrific and so very, very, very important. So anybody else? Anybody else? Yeah.
Yes. Yeah. So I'll echo what Dr. Trent said. And I think for where you are in your training to be this far along is amazing. And I think this speaks to the importance of advocacy to begin with. But I think one thing that really stood out, and insurance companies seem to maybe be the most equitable part of medicine, and that is denials for everybody. Okay. And so, I think it speaks to that challenge. We're addressing this on a state level, but I'm glad you brought up the potential for federal issues as well, because a lot of the Medicare is going to be mandated by federal legislation, which speaks to our multi-tier advocacy that's required. So kudos, I think great presentation and wonderful data.
Thank you so much. Thank you.
Well, if that's the future of medicine, I think we're in good hands. So, I also want to recognize our abstract competition committee, which is made up of a subset of our scientific advisory board. They work really, really hard at reviewing these abstracts. It is very, very difficult for them to select the winners, because we have so many phenomenal abstracts that come through, and they put a lot of work into that, especially our abstract committee chair, Dr. Jackie Turner, who was supposed to be here this morning with us. She sends her regrets. She had to attend a funeral, so we're sorry for her loss, but just want to recognize her for the hours and hours and hours of work that she puts in to make this happen. Our next presentation is going to be given by Dr. Elizabeth Chang. Elizabeth, are you here? Oh, great. Yeah, well, come on up. And she's from Tulane. And she is going to talk about in silico discovery of fusion-specific RNA biomarkers in pediatric leukemias. So again, we're seeing biomarkers, precision medicine. This is a big piece of it. So we're so happy to have Dr. Chang with us and hear about her research. Thank you. Yeah, welcome.
Okay, so first off, I would like to thank the leadership and the committee for allowing me the opportunity to present part of my research. My project is called In Silico Discovery of Fusion-Specific RNA Biomarkers in Pediatric Leukemias. So as we know, pediatric leukemia is the most common cancer in children, and progress over time has generally improved. The 5-year survival rate now exceeds 85%. It's up from under 50% in the 1970s. And during this time, the mortality rate in the US has also dropped by more than 1/2. However, despite these good statistics, persistent challenges do remain. They include relapse risk, where the rate is about 15%, and post-relapse survival is around 35%. There is a global survival gap, with the 5-year survival in low-income countries being under 40%, and in high-income countries above 85%. Some studies suggest that delayed relapse detection may lead to worse outcomes, and the diagnostic process itself is both invasive and costly. Now, while adult leukemia originates more from mutations and epigenetic changes, pediatric leukemias are predominantly driven by fusion genes. And this is a nice graph which shows the incidence of common translocations in AML. So the x-axis spans the age range from the infants to the elderly, and the y-axis shows fusion frequency. And each of the colored lines is a fusion gene, with the gray one being normal cytogenetics. As you can see, fusion genes are highly concentrated in the infant, children, adolescent, young adult range, and it tapers off in the adult and elderly population. So from here, we can see that fusion genes follow an age-specific pattern, and we could potentially use them as potential biomarkers in pediatric leukemias. And this leads us into a new class of transcripts called neogenes. So neogenes were discovered several years ago by Viber and his colleagues to be these novel multi-exonic transcripts that arise from silent regions of the genome, and they're not annotated in standard transcriptomes. And what makes them interesting is how they actually get turned on. So in normal tissue, there are a lot of these silent genomic regions where transcription does not occur. However, in fusion gene-driven cancers, there are these things called oncogenic chimeric transcription factors, which bind to these silent genomic regions and activate abnormal transcription. So here's a common example, the EWS Fly1 fusion protein Ewing sarcoma. It binds to this previously silent genomic region, and it starts activating transcription. When that occurs, it creates these Ewing sarcoma-specific neotranscripts that eventually get spliced and polyadenylated and becomes these Ewing sarcoma-specific neogenes. So from here, we can see that these neogenes are tightly linked to fusion genes, they're highly cancer-specific, and they're not found in normal tissues. And from a diagnostic perspective, this specificity is valuable as we can use them as potential biomarkers in pediatric leukemias. So the gaps in knowledge. Well, first, what is known? We do know that fusion genes create neogenes in sarcomas, and this is a figure taken from the Viber paper where they looked at 18 different sarcoma types, and they found that each of these neogenes or sarcomas have specific neogenes that are driven by these oncogenic chimeric transcription factors, which is shown in this middle panel. And it's specific because we don't see any of these neogenes in the top panel, which is from other cancers, and they're not found in normal tissues from this bottom panel. And from our previous graph, we have seen that pediatric leukemia is largely driven by fusion genes. So the unknowns now are, can we detect these neogenes in pediatric leukemia? Are these neogenes subtype specific? And are we able to use them as potential biomarkers? To do this, we assembled a custom bioinformatics pipeline to detect these neogenes using open source tools. We also use publicly available RNA-seq datasets. We first use a package called Star Fusion because we know that to confirm the presence of fusion genes, because we know that neogenes originate from these fusion events. We then use Star and Scallop, which helps us align and assemble the RNA-seq reads to a human reference genome. And then we use GFF compare to help us identify all of the unannotated transcripts. Then we quantify and normalize those unannotated transcripts. And then lastly, we filter candidate neogenes based on 3 criteria. The first, that it's highly expressed in our leukemia subtype of interest, that it is strongly upregulated compared to other diseases, and that it is minimally expressed in unrelated tissues. So after going through this pipeline, we came up with this heat map for the expression of neogene transcripts in acute monocytic leukemia. And to orient you, each of these columns represents a subtype. So in this left-hand panel, we have the 7 pediatric leukemia subtypes. And in the middle panel, we have 6 other common childhood malignancies, with the first 3 being non-fusion gene-driven and the last 3 being fusion gene-driven. On the right panel, we also have normal tissues. And each of these rows represent a neogene transcript. The color is normalized by TPM value, or z-score normalized by TPM value, which basically means relative expression across all samples, with red being higher expression and blue indicating lower expression, and all of it is on a scale. So we can see from here that these neogenes are highly or strongly represented in only acute monocytic leukemia and largely absent in the other subtypes, including other cancers and normal tissues. From here, we can see that using these neogenes, they are possibly be able to be used for diagnostics in AMOL. And more importantly, we repeated this pipeline for the other 6 leukemia subtypes, and we also found that they each have their own unique neogene signature. And this is a heat map combining all of the individual subtypes into one graph. And then on the right-hand side, we can see summary statistics of how many neogenes were initially identified through our pipeline and how many were left over after the filtering process. Now, to see if these in silico discoveries were actual transcripts and not just computational noise or artifacts, we decided to look into the specific region of some of these neogenes and ask the question, do they show markers of active transcription? So here's an example we use. This one is from CML, and this is neogene 152. There's 2 isoforms, so 1 and 2. And it's located on chromosome 3. So first asked, are these transcripts open and accessible? So we looked at ATAC-seq and DNA-seq. And for orientation, the x-axis is showing the genomic region, and the y-axis is just signal intensity. So from here, we can see both ATAC-seq and DNA-seq have strong signal intensity corresponding to the rightmost exon, meaning that these transcripts are open and accessible for transcription factor binding and transcription. We also looked at POLR2A, which is RNA polymerase 2, and we also do see strong signal corresponding in the same area, which means transcription is able to occur. We also looked at a couple histomarkers, particularly like ones showing promoter activity, activation, and elongation. So we can see from here, it shows sustained transcription. And all these data taken together allows us to see that these transcripts are real, they're not artifacts, and they're actively being transcribed. So the next steps we're going to take is to confirm these neogenes in vitro and in vivo, and then hopefully be able to detect them in our patient samples. Now, the natural question is, how do we integrate this into our clinical setting? So this is our conceptual model where our overall clinical challenge is relapse detection and its overall invasive and high-cost process and monitoring. Our traditional workflow for detecting leukemia basically occurs when a sick child is brought to their primary care by parents and initial labs are first done. If there's some cause for concern, they'll be referred to hem-onc specialists for potential biopsy, and then later sent for some cytogenetics. They'll need to wait a little bit for diagnosis, and if positive, treatment will start. And then our intervention is this neogene panel. Well, it kind of enters this model as a more streamlined NGS-based test where it's designed to reduce complexity, minimize invasiveness, and accelerate diagnosis. And the outcomes are early detection, decreased physical procedures, decreased emotional burden on patient and parents, faster treatment initiation, and overall lower cost. And the clinical and translational relevance of this, comparing conventional testing and our neogene panel, is that conventional testing usually requires flow cytometry, NGS, cytogenetics, PCR, bone marrow, and blood samples. It's highly invasive and often requires sedation and anesthesia. Whereas our neogene panel is one single NGS panel from one blood stick, it's minimally invasive and does not require sedation. It can also be done much more frequently and associated with overall lower cost. So our conclusion is that we were able to find subtype-specific neogenes in fusion-driven pediatric leukemias, and that these transcripts may serve as novel biomarkers. The clinical significance includes improved early and minimally invasive detection of pediatric leukemia, therapeutic monitoring of tumor progression or resolution. It'll help us pinpoint tumor of origin, and in the future, it might even lead to expanding the biospecimen potential, including like the urine, where it'll be completely non-invasive and much more readily accessible, and would be ideal for our pediatric patient population. And that concludes my talk for today. These are my acknowledgements, Dr. Lee's lab, our STAR committee, and thank you. I'm happy to take any questions.
Dr. Chang, that was incredible. Incredible research you guys are doing. I have a master's degree in human genetics. I run a precision medicine program. I work in genomics every day. And I learned more about neogenes during that presentation than I've ever heard before. So kudos to you. I appreciate that. And it's incredibly novel and potentially practice-changing research as well. So we may see our approach to pediatric leukemias completely change from this. So that is phenomenal. Our final presentation will be given by Dr. Maya Hammonds, who is from Ochsner, and her presentation is entitled Clinical and Economic Impact of Single Anesthesia Events in Surgical Management of Early Stage Lung Cancer. And her mentor is Dr. Jordan Dozier, who I saw in the audience here back there. He's one of our CAGLA Scientific Advisory Board members. We grade these abstracts completely anonymously, so we had no idea, but we're very happy to have one of our Scientific Advisory Board members as one of the mentors for this research. So thank you guys. Is Dr. Hammonds here? Ah, right there, coming up. Okay, great. Thank you. Welcome.
Hi, good morning, everyone. My name is Maya Hammonds. My voice is a little rough. I'm recovering from a cold, so sorry about that. But today I'll be discussing the clinical and economic impacts of single anesthesia events in the surgical treatment of lung cancer on behalf of my team at the Ochsner Medical Center. So currently, lung cancer remains the leading cause of cancer-related mortality in the United States, and one of the key issues in lung cancer care is delays in treatment. This has been shown to increase the risk of upstaging and worsen survival. The recommended time to treatment interval based on the STS and ACS guidelines is 6 to 8 weeks. With the traditional workflow, this requires multiple procedures, including a biopsy followed by time for pathology to get back to you, and then a separate operation. This creates multiple anesthetic events and opportunities for delays. With advances in robotic bronchoscopy and robotic-assisted thoracic surgery, we have an opportunity to rethink this pathway. And for those of you who don't know, because obviously I'm on the surgical side of things and not genetics, robotic bronchoscopy lets you upload a patient's CT scan into their programming and allows you to map directly to the nodule and take a biopsy that way. It's a lot more specific and lets you get a lot deeper into the chest cavity than traditional biopsy methods. So for the SAE concept, or single anesthesia event, this combines diagnosis and treatment into one operative session. Patients undergo a robotic bronchoscopy and rapid on-site evaluation, what we call the ROSE, is used to confirm malignancy intraoperatively. Basically, it's sending frozen pathology down to the lab and they get back to you within 10 to 20 minutes. So if cancer is confirmed, then patients are immediately transitioned to a robotic surgical resection of that cancer. And the goal of this is to reduce time to treatment interval while maintaining patient safety. So here I'm highlighting the kind of key differences in the workflow. They both start with a CT detection and then referral to pulmonology. But then with the traditional pathway, first they get a bronchoscopy or some other type of sampling for a biopsy. Then you have to wait for pathology, and then you see your pulmonologist again, and then you schedule surgery, and then eventually you get a resection. And that usually takes about 12 or more weeks. With the SAE pathway, it's consolidated into a streamlined process, reducing the timeline to approximately 6 weeks. And this represents a major opportunity for us to improve efficiency in lung cancer care. So the objective of our study was to compare the SAE approach to the traditional pathway in early stage lung cancer. Specifically, we evaluated whether the SAE model reduces the time to treatment interval, maintains safety, and impacts hospital costs and revenue. For a new model like SAE to be sustainable and adopted at scale, it has to be good for patients and sustainable financially for the healthcare system. So this was a single center retrospective cohort study conducted from 2021 to 2024 of patients undergoing robotic bronchoscopy and robotic lung resection, which we divided into the traditional pathway or the single anesthesia event group. We had IRB approval for this, and the data came from an institutional registry. For our inclusion criteria, it was all adult patients with suspected early stage lung cancer, which is defined as tumor stage T2 or less without nodal disease. We did exclude patients that were higher risk, including those with nodal disease, stage greater than T2, poor pulmonary function, difficult airway, prior complex thoracic surgery, and some others listed here. This ensured that we had a relatively comparable operative cohort. So for our outcomes, we were looking primarily at imaging to surgery interval. That was one of our main outcomes, pulmonology visit to surgery interval, and postoperative complications. Secondary outcomes that we looked at included length of stay and direct costs and net revenue. So for our cohort, we had a total of 62 patients, 42 in the traditional group and 19 in the SAE group. For the baseline demographics, including age, pulmonary function, and smoking history, they were similar between the groups. So for tumors, and this is all on the final pathology, adenocarcinoma was the most common subtype. The SE cohort did have slightly smaller nodules measuring about 1.5 centimeters at median compared to 2.1 centimeters in the traditional group. However, all tumors were early stage. So outcomes, for the time to treatment outcome, one of our key findings was that from initial imaging to the surgery, the interval decreased from 84.5 days in the traditional group to 48 days in the SAE group, which was highly significant. Similarly, from pulmonology visit to surgery, the time decreased from 62.5 days in the traditional group to 38 days in the SAE group. Overall, the SAE pathway reduced time to treatment by more than 1 month. So in terms of safety, there were no major complications in either group. That included respiratory failure, myocardial infarction, pulmonary embolism, and unplanned return to operating room. And readmission rates were also similar. There was no 30-day mortality for either group. We did have minor complications in 33% of the traditional patients and 0% in the SAE group. And those complications included an air leak lasting greater than 5 days, atrial fibrillation, pneumonia, and a chyle leak. So this suggests that our streamlined pathway did not compromise patient safety. So for our financial outcomes, we saw that from a financial perspective, direct costs were not significantly different between the groups, but we did have net revenue that was higher in the SAE group, suggesting that SAE is not only clinically effective, but also financially favorable for the hospital. So overall, our findings demonstrate that the SAE approach reduces time to treatment by more than 1 month, which meets the STS-ACS recommended 6 to 8 week treatment window, does not negatively impact safety outcomes, and has favorable financial implications. So we know from previous research that delays of treatment greater than 8 weeks following initial radiologic detection of lung cancer are associated with worse outcomes, which include reduced median survival, increased 30-day mortality, and an increased risk of upstaging. We also did not directly measure this, but believe that this may improve patient experience by reducing delays and reducing care fragmentation, which should reduce patient anxiety and time burden. We did have limitations in our study, primarily that it was a single center retrospective cohort study and it had a small sample size. We also had 2 benign resections in the SAE group. These were tumors that on the rapid on-site evaluation, they had atypia or concerning features, and then they also had radiologic features consistent with malignancy before we scheduled these patients. So that was also a limitation. For future work, definitely needs a larger prospective studies to really get this off the ground, and evaluation of long-term impacts on survival. Also, I think it would be important to do assessment of patient-reported outcomes, including their quality of life. So in conclusion, the single anesthesia event pathway significantly shortens time to treatment interval, maintains comparable safety, and improves financial performance. This represents a promising streamlined model for lung cancer care. Thank you for your attention. I'm happy to take any questions.
All right. Any questions or comments? Yeah.
So this is fabulous and gets me really excited. I wanted to kind of time back to the first presentation. What did this look like? You know, obviously prepping these patients, going in for a certain procedure, those that didn't turn into having a resection. Did you find that those patients experienced higher denials on the back end? You know, concern for those patients being hit later on with financial responsibility. What did that look like for those patients?
So I'm a first-year surgery intern, and I was not there, unfortunately, when this was all going down in the original data collection. However, I do know that Ochsner primarily serves people that are insured, or and I think a larger percentage of our patients have private insurance. So I think that would be less likely to be an issue with our patient population.
You know, went ahead and proactively authorized for both the initial procedure and the surgery as potential, or kind of what that first was.
So, so I know this, longer and when we do the fire off, for the sequence, we did go over the system. And it's because my suspicion, but growing and more awareness of it. We're doing these for all non-rural and low index. We haven't.
That's phenomenal. And just knowing that the patients are getting to the too. Great job.
Thank you. Any other questions?
Thank you so much. Absolutely phenomenal work. Definitely benefiting patients. And I think we're hearing a theme here with Dr. Delavicio's presentation and this presentation that we can do really complex things, but it's hard. But it's worth doing, worth coordinating these things. We have a little break. We will meet again at 9:30 in our tracks. Track 1 in here, hematology. We're going to do our precision medicine and prevention and early detection in track 2. Track 3 will be neuro-oncology, and track 4 gynecology. So please feel free to go grab some coffee, go to the bathroom, and we'll see y'all in a few minutes. Thank you.